Okay, so let me. Okay, thank you very much. Hello, everybody. Welcome to this webinar on fungal and atypical keratitis. We are honored and fortunate to have a galaxy of international experts in this webinar. They are all experts in the field, and I hope we'll have a good and informative webinar, and we can deliver a webinar that is useful for everybody, because I think this is a subject that has not been presented where, unlike other subjects, and it is, I think this is an interesting subject. In this webinar, we will have as a speaker Dr. Fasika Woreta from US, and Dr. Kendrick Co Shih from Hong Kong. Also, we have Dr. Prajna from India, and Dr. Said from Germany, and Dr. Namrata Sharma from India as panelists. And I am Dr. Muhammad Warishi from Iran as moderator, and we have Dr. Soleimani, my colleague and my friend from Tehran University of Medical Sciences, as moderator also, and also he will present some cases. So I would like to ask Dr. Soleimani to start saying words, and he will maybe present some initial cases that would be interesting for the beginning. So Dr. Soleimani, can you start?
Yeah, would you please introduce Professor Said and our panelists?
Oh, yes,
actually,
because, okay, I will introduce our panelists, and Dr. Soleimani will introduce the speakers before they start speaking. So today we are honored to have the Professor Berthold Said from Germany. He is Professor of Ophthalmology and Chairman of Department of Ophthalmology of at Solna University Medical Center in Hamburg, Germany. And he's also Director of ICO Fellowship and also Head of Cornea Section of German Ophthalmological Society. He has numerous publications and papers in the literature, and has written many chapters in the books, and also has thousands of citations. We will have as panelist Dr. Namrata Sharma from India. She is Professor of Ophthalmology, Cornea, Cataract, and Refractive Surgery Service at the Rajendra Prasad Center of Ophthalmic Sciences, All Indian Institute of Medical Sciences, New Delhi, India. And she's also Honorary General Secretary of All Indian Ophthalmological Society. Dr. Sharma. Okay.
Yeah.
Do I have to stop sharing my screen? You can share your screen, or I have to stop it?
I stopped.
Try sharing. Okay.
And I am trying sharing my screen. IT team, can I share my screen?
Yes, doctor, you can.
Yeah, but I cannot share right now.
You have to open your PowerPoint before and then you share a screen. So
yeah.
First,
but I cannot share.
First, try to open your application, your PowerPoint.
Okay.
Okay, good. That's good.
Okay. Hello, everybody. So once again, I welcome everybody for this topic on fungal keratitis. Actually, why are we talking about fungal keratitis? Mycotic keratitis, mycotic keratitis is an important and dangerous etiologic agent for infectious keratitis. Before introducing Professor Prajna and others, there is no financial interest in any material of this lecture. Actually, fungal keratitis could involve the result of any surgery in ophthalmic surgery, such as this patient with bilateral post-PRK fungal keratitis. It could affect the result. You see that it could affect the result of every surgery, or it could affect also post-smile surgeries, such as this patient with post-smile fungal keratitis, and it could actually manipulate the corneal graft result, such as Dalk and Deseg, such as these two patients. The first one in the left side with fungal keratitis after Dalk, and the second one in the left side, in the right side, with the fungal keratitis after Deseg. Also, it could result in severe devastating ocular problems, including corneal perforation and endophthalmitis, such as this patient with an extensive fungal keratitis. The other part is talking about atypical forms of keratitis, including Nocardia microsporidial and Mycobacterial corneal infection, that is necessary to pay more attention to them in our differential diagnosis list for keratitis. In this webinar, we have a well-known great master from all over the world in this talking, and it is our honor to benefit from their valuable experience. Actually, I gonna introduce Professor Prajna. He has been working in Aravind Eye Hospital as a consultant in the Department of Cornea Service for over 2 decades, and has been the head of the department for the past 10 years. He has been instrumental in developing the department to be one of the largest corneal facilities in India, seeing a large number of infectious keratitis in the country. Apart from his clinical commitment, he has a special interest in basic and clinical research pertaining to corneal infection. He has actually over 150 peer-reviewed publications in famous ophthalmic journal, and he is a member of Assessment and Examination Committee of International Council of Ophthalmology, or ICO, during the past years. He has been a recipient of large competitive grants from NIH and other public organs, and he has written over 10 book chapters and 3 books, and he is the chief editor for Payment Principle and Practice of Ophthalmology, the 2nd edition. Professor Prajna, would you start your presentation, please?
Yeah, so we need to, okay, so I'll open my screen.
Actually, we have Professor John Dart right now. Professor Co Shih, would you actually introduce Professor John Dart?
Yeah, I would. Dr. John Dart is well-known ophthalmologist. He doesn't need to have an introduction, because he's expert in corneal surgery, corneal diseases, especially ocular surface. And just I would say hello and welcome to him. So we will have any comments that he may have during the meeting.
Thanks very much. It's lovely to see you all. Namrata, Mohammed, Prajna.
Okay. Thank you.
To see you.
Can I go?
I'll shut up now.
Always a pleasure to see you. So I hope that you see my slides now.
Yes.
Yeah. Very good.
So thank you, Dr. Qureshi and Dr. Sulaimani and the entire Iranian Society of Ophthalmology for this kind invitation And what I thought was, in the next 20 minutes given to me, I would concentrate on mainly the work which I'm personally doing. So I might be missing out on other works, but I think that would be much better to concentrate on the work which I have done so far in this field. So my talk would be basically divided into these three sections. And I'll just go for the first section, that's on the diagnosis of the fungal keratitis. I would just like to share one of my experiences in doing a very interesting study. So we gathered a group of cornea specialists. These were not residents, these were not fellows. These were established cornea specialists from the US and India, and showed them some clinical pictures and asked them whether what they thought of it, whether it was bacterial or fungal or acanthamoeba, and this thing, just by showing pictures. And it was a very interesting observation for us that only 60% of the time the established cornea specialists could establish a clinical diagnosis by seeing the pictures. So, as I often tell to my residents, fungi and bacteria don't read the textbooks, so they don't know how to present. And so we need microbiology to confirm our diagnosis. To confirm that fact, let me show you 4 circular ulcers, each competing for the price of a perfect circle caused by 4 different microorganisms. So this, if you had just read the textbook, we would have thought that it was caused by acanthamoeba, but here you can see 4 different organisms causing a circular corneal ulcer. And only by microbiology and using these regular methods, you don't require culture in all your routine activities, but at least you need light microscopy before you venture to treat. So that would be my first stress before I actually go on to my presentation. So let me spend some time on confocal microscopy with very specific things pertaining to fungal keratitis. So we have these 3 publications from 2016 to 2017 on confocal microscopy, looking at the organism, looking at corneal cellular changes, and also looking at inflammatory cellular changes. So the main reason is, before we actually ventured into this presentation, to this publication, there were very good reports which said that based on confocal microscopy, we could diagnose whether it was caused by Aspergillus or Fusarium. So we ventured to look at the filament branching angle, the adventitious sporulation and dichotomous branching, and we wanted to see whether there was any difference between Fusarium and Aspergillus which could be caught by the confocal microscope. So our findings were actually otherwise to the presentations which were published before. We could not see any difference between Fusarium and Aspergillus with regard to filament branching angle, nor with adventitious sporulation, and also there was no difference with regard to dichotomous branching. So we came to a conclusion that there was no difference in the branching angle of Fusarium and Aspergillus based on our findings using an HRT IVCM. And we concluded that IVCM cannot effectively distinguish Fusarium from Aspergillus. But what we found was, there were distinct cellular changes with regard to these organisms. Normally, you could see the normal cells, the cellular structure is something like what you see in the left. But when the structures are associated with fungal keratitis, you could see a very good honeycomb distribution of inflammatory cellular structures, which seem to be typical of fungal keratitis. And within this honeycomb, Fusarium, when the cornea is invaded by Fusarium, they tend to show with stellate interconnectivity with nuclei, which is much more seen. But what is more striking is the inflammatory cellular changes. That is, we know that Aspergillus causes clinically more severe fungal keratitis, and the dendritiform cells, which are known to be markers of inflammation, which get excited by inflammation, are much more pronounced in Aspergillus keratitis than in Fusarium keratitis. In our series, this was, if you saw DFCs, if you saw dendritiform cells, then the chance of the increased dendritiform cells were more seen in ulcers caused by Aspergillus. That was our confocal work, but this is something which we are now working from pulmonologists, because pulmonologists have long worked with Aspergillus, and for them, they've worked with Aspergillus of the lung, and so we are now working with University of Edinburgh on a project which we think is very exciting with regard to diagnosis. So this team is actually a team without ophthalmologists. Everybody is there in this team, to be very frank. We have physicists, biologists, machine learners, and this thing. But what basically they do is they've been using this technology on patients in the ICUs when they really want to know, when they really take a picture, where they want to see whether it's caused by infection or not. And so what they do is they sort of spray these agents into the lung in microdoses, and then sort of photograph it, and basically you tend to see inflammatory. You can differentiate between infective pneumonia and inflammatory changes in the lung using this technology. So what we decided was, if it could be done in a lung, could we do a similar thing for a corneal ulcer? Can we actually diagnose using a simple technique at the field whether this ulcer is caused by fungi or bacteria or gram-positive or gram-negative bacteria? So we use these are called smart probes. And what we showed, this is at this point of time, we have looked at the smears in the microbiology lab, and we are able to find out very quickly by just spraying this, whether this organism, or whether this is caused by fungi, gram-positive bacteria, or gram-negative bacteria. So we published this year for rapid detection. So what I see is, it's very easy. We are now actually working with Aurolab, our manufacturing division, to develop some sort of a fluorescent device which can be made for a cost of less than 100 rupees. It's very cheap. And if we can make that device, then if we apply the smart probes, we might probably be able to use this as a screening tool at the primary level to find out whether it's caused by fungi or bacteria. So this, I think, we have a scope, and anything we do, we like to actually bring down the cost, and we also would like to be used at the primary level, and we really think that there is some scope in this modality for diagnosis. So that was about the diagnosis, and coming on to the management. So if you see any RCTs with corneal ulcers, you see the last line. This is usually the way it concludes. But I was fortunate to be a part of the clinical trial, the MUD study, where we were actually told to stop. We had an independent data monitoring committee which asked us to stop the study 20 cases before the actual completion, because the difference was actually found in this clinical trial. So what did this study find? This study found that natomycin was better than voriconazole. This was for all organisms, but the most interesting part of this study was in Fusarium cases, this superiority of natomycin was accentuated. So for the first time, we were reporting that certain fungi respond to certain antifungal drugs better than other antifungal drugs. We always knew the story in bacteria. we knew that gram-positive bacteria responds to different drugs and gram-negative respond to different drugs. But this study came to a conclusion that one drug was better for one fungi. In non-Fusarium cases, let's say Aspergillus, there was not much of a difference between Natomycin and voriconazole, but still there was a slight superiority even for Aspergillus. But at this point of time, I would like to stick my neck and say for Fusarium, Natomycin is a much better drug than voriconazole. So interestingly, this was very interesting. Other investigators from India actually did a reappraisal of the same study because it was actually slightly different from what we were perceiving. So this study done by independent investigators also came to the same conclusion that Natomycin was better, and it was more better when Fusarium was the subject of interest. So we went on to perform a MUT2 because we had already started MUT2 when before the results of MUT1 had come. We wanted to see if we add oral voriconazole to topical antifungal agents, that is to topical Natomycin, was it better or was it making some difference? So what we found was there was no benefit in adding oral voriconazole when you do a randomized controlled trial, especially for severe fungal keratitis. So why did this happen? Because we knew in 2002 and 2004, voriconazole, when it came up, it came up with a lot of promise. It came up with a lot of promise because after a long period of time, we had a wonder drug to which 100% of the lab organisms were susceptible. But then over a period of time, something changed. As you know, Natomycin is not used outside the eye. It is not used for systemic fungal infections. It's not used for agricultural fungal problems. But voriconazole was used everywhere. And because of that, probably the susceptibility for voriconazole just decreased with time. And by 2013, 2014, when we did the results, we found out that it was not the same wonder drug what it was in 2002 and 2003. So the results of our clinical study, before we started, I was also in this camp before I did this RCT. If I had been asked this question, I would have also answered that I preferred voriconazole. But after the results of this study, we find that this study has really influenced a lot of people to question themselves for their affinity for voriconazole. The next part of my work has been in cross-linking in fungal keratitis. We know that there are two mechanisms. One, the antimicrobial mechanism, and the second is anti-inflammatory mechanism, where it sort of strengthens the collagen. We are now actually just finished doing the study called the cross-linking assisted infection reduction. We just published results of this. But the initial part of it was, we were doing it in 2015. We wanted to see whether if we just add cross-linking to the standard antimicrobial care in fungal keratitis, was it any useful? But what we found was, you just see this place here, in the cross-linking group, there was significantly lot more perforations than in the non-cross-linking group. So we were criticized because we actually looked at deeper fungal keratitis. And so we decided to do a new study. We said we'll take all cases of fungal keratitis, not limiting to the deep fungal keratitis, and ask two questions. Is cross-linking beneficial? And second, is topical amphotericin, how does topical amphotericin compare to topical Natomycin? So we had four groups, an Natomycin group and an amphotericin group, and a cross-linking added on to these both groups. To keep, we had culture positivity at 24 hours as the primary endpoint. And to keep a long story short, this was at 3 months follow-up. What we said was it does not reduce the odds of having a positive culture, that there was no big effect. But the same thing, I'll just veer a little bit away. When we did for a bacterial keratitis component, it had a promising result. It had a much more promising result. But in fungal keratitis, in fact, it might just decrease visual acuity. And then there was no difference between topical amphotericin and topical natomycin. We published this in February of this year. But what we also did was we followed this whole group for a period of 1 year to see whether the visual acuity disturbance was getting better. Because as you know, initially there may be a lot of scarring with the cross-linking group, and that could be the reason for decreased vision. But what we found is even at 1 year follow-up, there was still a negative impact on visual acuity without much of being used. So this has been accepted in ophthalmology to soon be out. So we don't think cross-linking using a Dresden protocol, and I would like to emphasize that point at this point of time. Cross-linking using a Dresden protocol does not seem to offer too much of a benefit for fungal keratitis. So I come to the final part of my presentation on what I have learned throughout all these 15 years of research in fungal keratitis. We have to understand that disease, the fungal keratitis, is actually the result of the interplay of the agent and the host. But our whole theme of attack has been just on the agent. And I'll tell you the reason why this might not be a great idea through some series of observations on these things. So we know that there is a difference between Fusarium and Aspergillus with regard to all these things. We said Natomycin is better for Fusarium. Natomycin is the drug of choice for Fusarium. So we know that there is a difference in antimicrobial susceptibility pattern. And then I'll just briefly touch upon the morphology and the host response. Clinically, there have been 2 publications from our group where we show that clinically Aspergillus has an increased risk of perforation as compared to Fusarium. It has a worse visual acuity at 3 months and is also associated with lower reepithelialization. So we know that there are 2 distinct group of fungal ulcers we are dealing with. We also have evidence from our lab. This is not just on the clinical sample, but also the lab sample, which also says that Fusarium is less susceptible to voricon. So again, we know that there is a difference between Fusarium and Aspergillus. And here you see in the lab, there are completely, these are 2 different organisms. You know, they may just form under the common thing called fungi, but as you can see, the SEMs, you can see this is Fusarium and this is Aspergillus, and you can see that there are completely 2 different organisms. But what is more interesting is within the Aspergillus, this we are actually working with Pasteur Institute in Paris, where we are working with pulmonologists. We're working on Aspergillus fumigatus in the lung, and we are working with Aspergillus flavus on the eye. And we see that the rodlet, that is the outermost surface of the fungi, outermost surface of the Aspergillus, there are distinct differences between the outer covering of fumigatus and flavus, and this has got a role to play in stimulating the human immune defense mechanism. So if that was not enough, we have found out something more interesting. In the mud study, amongst the Fusarium isolated, we said 80% of Fusarium samples were Fusarium solani. So what is the big news on that front? What we also found was amongst the Fusarium, Fusarium solani isolates are associated with worse baseline cornealoplasty. So within Fusarium itself, there seems to be a difference in the sequelae, which is actually left behind. And see this, these are all Fusarium from mud samples, and we work with the Dartmouth College, the microbiology here, and you can see multiple differences in the areas of in the pigmentation capacity of these microorganisms. So within Fusarium solani has more scars than the other Fusarium. Within Fusarium solani, you have much more differences with pigmentation, which shows that there are differences in virulence between Fusarium solani samples. And amongst the host response, this is also very interesting. So this is we measured the zinc alpha glycoprotein levels in the tear from the patients. In one group, it actually decreases, and in one group, it actually increases. And this also we published in 2 studies in 2013 and 2019, showing that the immune response of the tear or the protein production seems to be different when the eye is attacked by Fusarium or Aspergillus. So I like this slide very much. So whenever you see amongst human beings, they're all belonging to one group, one genus, but then their virulence pattern is completely different. And this is what we need to understand when we deal with this microorganisms. I talk about this slide in almost all the meetings to drive home that point. We need to actually look at these organisms much more closely. So what I see as the future of treatment, I come to my last slides. So today we are treating everybody with Natomycin, but tomorrow or in the future, it would be a combination of an anti-infective drug with a selective anti-inflammatory drug. If I get infected, I would be treated with a drug called Natomycin P. If Dr. Soleimani is getting infected, he'll be getting treatment with Natomycin S, where the P and S will be tag proteins, which will be modified based on our immune response. And that is the way to go on treating this fungal keratitis. This may look like something which is very, very unimaginable at this point of time, but 50 years later, people would be ridiculing us, would be laughing at us that we treated everybody with the same group of medicine. You know, we look at the, when penicillin was discovered, everybody was treated with penicillin. And we now know that that is not the end of the game. So I come back to this slide. So we have been so far concentrating on killing this fungi and then imagining that the whole process will get better. But what we need to concentrate would be this interplay, which is actually, as I showed you in a series of experiments, it's not as simple as it sounds. So this is my last slide. There is a considerable variation existing between fungi, not only between Aspergillus and Fusarium, but even within Fusarium, Fusarium solani and others, and even within Fusarium solani. And there seems to be differing host response to differing fungi. Killing the agent does not necessarily mean controlling the disease. All of us know it. 2 people start off with the same size ulcer. You apply the same medicine, one heals, the other doesn't. So we need, this is my last, this would be my quest in the rest of my research career, to actually look for topical selective immunosuppression. Can we actually use a topical interleukin IL-17 suppressor? Or can we use an IL-23 suppressor, which can, or an IL-6 suppressor, which works topical, which will take care of controlling this disease very much. So once again, thank you very much for this opportunity, and I do hope that we will have some questions from this. Thank you very much.
Thank you very much, Professor Prajna, for this very excellent presentation. You already addressed the challenging issues, but I'm sure that there will be questions and discussions. So I want to ask Dr. Soleimani to look at the chat box and Q&A, and if there is any question, please.
Dr. Perman asked about the accessibility of Natomycin, and we know that we have right now voriconazole in Iran. Natomycin is a little not in access. And Dr. Kendrick said and asked about the role of debridement for fungal keratitis treatment from Dr. Prajna. Professor Prajna, what is your opinion regarding debridement of fungal keratitis and the role of it for treatment?
So we have some contradictory report. In my initial pilot study, we said repeated scrapings can cause a decreased visual outcome over a period of time. But now I do scraping, and then it really depends on the on the ulcer. Some of the times you can see a fungal plaque sitting over the cornea. In that case, I really see a use for taking the scraping, but not. I'm not in favor of doing repeated scrapings every time.
Thank you, Dr. Prajna. I think, yeah, thank you. I think we will have a discussion on surgical management of especially fungal keratitis later on, and we'll discuss maybe the surgical options. But regarding the natomycin, unfortunately, there are limited numbers of antifungal drugs available, and natomycin, unfortunately, is not available in my country anymore. It was before, but maybe the company has a policy and a strategy not to distribute too much. I don't know if the availability in natomycin in other countries. You also mentioned that voriconazole used to be a good drug, but I think it has been overemphasized. When a new drug comes, the people start using that, but over time they will see that maybe the effect is not that much that was anticipated before that. So I think there can some panelists talk about the availability of antifungal drugs in their region and their country. And I think we start with Mr. Dart. John Dart, can you comment on that, the availability of antifungal drugs in your practice in UK? Can you activate his
John, you're muted.
You're okay. You're okay. Yeah, you're audible now. Yes.
Thank you.
Oh.
John, we cannot hear you. We cannot hear you. Unfortunately, can you unmute your?
Please activate your microphone.
Is it working now?
Yeah.
I think it's okay now. Yeah. Yes.
Thank you.
Yes.
Prajna, that was a marvelous talk. And well, to answer your question, after the MUT study came out, we completely changed our protocol at Moorfields to follow really MUT study guidelines, and we imported natomycin, which we hadn't used before. We'd followed the previous. We don't have that much filamentary fungus, although it's increasing, and fusarium is now. We see about 15 cases a year in contact lens users, which is new for us. So we are getting some experience managing it. We've imported Prajna's protocols, and we need to re-audit our outcomes. But the reason we changed our protocol was because our keratoplasty rate in filamentary fungus keratitis was about 50%. Now, difficult to compare one center with another, but ours was very poor. So we had no problem changing our protocol to follow the MUT study protocol, and we can import natomycin. I have a relevant question for Prajna to this, because we use Amphotericin 0.15%. And I just wanted you to clarify, Prajna, the setting in which you found there was no difference between Amphotericin and natomycin in your recent paper, which I should have read, but I hadn't. And I will look it up when this is over.
Yeah, so actually, John, the primary aim of that paper was to look at the efficacy of cross-linking. And then we also said, so that's why the primary outcome was actually microbiological cure within 24 hours. So it's not really powered for finding out the difference between the drugs, but we were actually criticized for not using Amphotericin B, and so as an afterthought, we actually added on to this cross-linking part. But in that limited sample over a period of 1 year, we couldn't really find a difference between Amphotericin and.
So I just wanted to clarify that there was that we don't think that Amphotericin is going to be particularly useful for fusarium or some of the other filamentary fungi. I mean, we use it for Candida. In fact, we published probably the largest series of Candida because we still see quite a bit of that in our surface disease patients. And Amphotericin is a very good drug for that still, at least for Candida albicans. Voriconazole may be better for Candida parasilosis and some of the other Candida species. Thank you.
Thank you, John. Do other panelists have any comments on the management of fungal keratitis? Professor Said and Dr. Sharma, do you have any comments regarding the practice using antifungal drugs in your country, in your region, in your practice?
I think there was a question about the interstromal application of voriconazole. What do you think about that?
Okay, that is also a good question. If anyone of the panelists can address this question, it's good. Yeah.
So
Namrata needs to speak about it.
I actually wanted to suggest Namrata because she has done both an RCT as well as a finding. Both.
Okay, good.
Myself. Okay, I've unmuted. So at the outset, I would like to thank Dr. Qureshi and Dr. Soleimani for having me. It's a complete honor, and I'm so delighted to be with John Dutt, who's my mentor, and I've done my fellowship with him. I mean, my day is made today after seeing him. And of course, with Dr. Seitz and Dr. Prajna, he's done remarkable work in fungal keratitis, which has changed the way we treat fungal keratitis, the way we look at it globally for everybody. So regarding the intrastromal injections, we did start giving intrastromal injections with good results. And at that time, we used to take initially cases which were for herpetic keratoplasty. So sometimes we got good results and sometimes we didn't. So that's why we did this randomized control study to see whether intrastromal injections works or it doesn't work. I do believe that for that particular RCT, the sample size was not that big. But I do believe that they do have a role in those cases where your topical drugs are not working. I think both me and Dr. Prajna did discuss that when you add to natomycin voriconazole, it tends to have a little additive effect. That was also a part of that study only from which we realized. And if you give intrastromal injections in selected group of patients, not in all group of patients, but in selected group of patients, where your size of the ulcer is about more than 5 millimeters, depth is more than 50%, then I believe in selected patients it does help. And we have done a randomized study where we compared voriconazole intrastromal versus amphotericin intrastromal versus natasol. Natasol is natomycin, which is linked to a polymer to make it soluble. And we found the best results with natasol. Unfortunately, it's not available because it was made in our pharmacy. But second best was voriconazole, and with amphotericin D, we found that the scarring was much more, vascularization was much more, as opposed to this. So I do think that intrastromal voriconazole in the dose of 50 microgram per 0.1 ml does work. And again, I would like to acknowledge Moorfields Eye Hospital and again Dr. John Dutt's time when we were, looking at this dose, how much dose of voriconazole should be given. And in a patient who came to Moorfields, we worked it out with the pharmacy of Moorfields, and I'm sure John would remember about it. We worked it out to 50 to 100 micrograms, and that was intracameral injection, not intrastromal injection that we gave in that patient. So this is how the dose was worked out. So I do believe in selected cases, it does have a role when combined use of topical natomycin and voriconazole does not work for 4 weeks. That is what we have, said in our TST protocol, or topical systemic and targeted therapy for fungal keratitis, which we have published.
Thank you, Dr. Namrata. I think John has a comment.
Well, I don't want to take too long, but I suddenly remembered that something that you might like to know, Mohammed, is that chlorhexidine 0.2% is in actually 3 large trials in northern India or Nepal and in Africa, run by Matthew Burton, who's one of our best clinical scientists working largely overseas, funded by Wellcome. And he will very soon have some data on whether natomycin or chlorhexidine 0.2 is the most effective in the population in North India. I can't say any more about it, but the data's gone to the Data Monitoring Committee. And I think they will have a result very shortly. And chlorhexidine 0.2 is easy to make up, and that's why that was included in that study. So that's quite an exciting piece of work, and the trials are enormous, similar to Prajna's, and I think that will make a major contribution to our treatment for or understanding our treatment of filamentary keratitis. Can I've got one more comment on Namrata's on the intrastromal injection.
Okay, sure.
Namrata, I brought this up with you before, but I like you and Prajna, I've the few cases I've used it on, if I've used it late, I've been to try and patients who are stable but not improving, or have got a little bit worse before, you know, when they've been 2 or 3 or 4 or 5 weeks out. I think the intrastromal injection has been useful. When I've used it very early on in the early days, I've had 2 severe inflammatory responses. This was when I was using it at the same time as starting topical therapy, and I've been a bit nervous about using it early for that reason in my very small case series.
Maybe I can add something there.
Oh, yes. Sure.
Recently, I had also Fusarium keratitis, and I tried to do a little lamellar resection and then put the voriconazole intrastromally around it. And I had the impression that it became worse, and it even had some new focus more close to the pupil. So I also am not very keen doing that in the acute phase, as John says.
Okay, thank you very much. If there is no question from other panelists, comments from other panelists, or no question from the audience, we can continue and move to other session. Dr. Suleimani will present, I think, 2 cases of fungal keratitis, and we will discuss them. And after that, we will have the next presentation. Dr. Suleimani, can you go ahead with your presentation? Okay, yes.
The IT team, would you please share my screen?
Sorry, doctor, you have to share your schema yourself. I'm not able to share your screen.
Dr. Suleimani is working in emergency room of Farabi Hospital. It is a tertiary center. He has a long experience with these cases, and he sees very complicated cases, and I'm sure he is presenting very nice cases. Can you share your screen, Dr. Suleimani?
I'm trying.
Dr. Suleimani, on the bottom panel, you can see share screen.
Yeah, I have shared my screen too many times.
But before that, you have to open your application. You open your presentation first and then share a screen. It works better if you do this.
Yeah. We can continue to the lecture of Dr. Woreta, and then actually introduce my cases, I think, because my screen doesn't share right now.
Okay, maybe we will have. This is a presentation from.
This is the.
Okay, from Dr. Woreta.
Yeah.
All right, good morning, good afternoon, good evening. So I'm going to be discussing, I have 3 case presentations, and I really want to focus on the diagnosis of atypical corneal infections, and rather than the treatment and management. So I have no financial disclosures. And so again, I'll present 3 cases, and we'll just briefly discuss the differential diagnosis and highlight key pearls in the history for the early diagnosis of these 3 presentations. So, so the first 2 cases are from my colleagues. And again, I'm not going to focus on the management as much, but in terms of the key history and clinical findings, and to make the diagnosis, because these are commonly misdiagnoses. So case 1 was a...
Dr. Woreta, let me please introduce you before your presentation. Also, my screen cannot be shared. I actually, Dr. Woreta is an assistant professor on ophthalmology at the Wilmer Eye Institute. She specializes in cataract, corneal, and external eye disease and ocular trauma. Her research interests include ocular trauma, medical education, and quality improvement in healthcare delivery. She completed her residency in ophthalmology at Wilmer Eye Institute and then completed her fellowship in cornea and refractive surgery in Bascom Palmer Eye Institute and also an ocular trauma fellowship in Moorfield Eye Hospital. Dr. Woreta returned to Wilmer Eye Institute to join the faculty as Assistant Chief of Service and Assistant Director of Eye Trauma Center at Johns Hopkins Hospital. Actually, she is currently Director of Eye Trauma Center and Residency Program Director at Wilmer Eye Institute. Dr. Woreta, please. Continue.
Thank you, Dr. Soleimani and Dr. Ko Shih for inviting me, as well as the Iranian Society of Ophthalmology. It's a pleasure to be here, and I look forward to the discussion. So I'll go to the first case, which was a 33-year-old man with a history of LASIK in 2004, who was referred to the cornea division at Wilmer in 2018 with from the NIH, as well as an outside large medical specialty and the diagnosis was refractory keratouveitis in one eye. The patient was healthy and only had the past ocular history of the LASIK, was not a contact lens wearer, and he was in the armed forces. And in 2016, after returning from Afghanistan, did develop a left-sided swelling and was actually diagnosed with zoster keratouveitis at that time, but never had a classic vesicular rash. And the treatment prior to presenting to Wilmer was complex, and he was on intermittent Valtrex and topical, and also he had a history of being on oral steroids, and because of that had a lot of problems with intraocular pressure elevation, so was on maximum medical therapy as well as even Diamox. So and on the history that we obtained from the outside ophthalmologist, there was a stromal keratitis without epithelial involvement, and also recurrent anterior chamber inflammation. Because of the pressure, they wanted to do a tube shunt, which the patient deferred, and he had an extensive infectious and inflammatory workup, as you can see here, both with serum tests as well as an anterior chamber tap. This was done, again, all before he came to Wilmer. So when he came to our institute, the vision was 6/9 in the affected eye. And so he was examined by one of our cornea specialists, and incidentally found to have some Demodex on the lashes. And then I'll show you the picture of what the infiltrate looked like. And again, he did have this history of LASIK, and you can see this supranasal infiltrate here. And again, there was no epithelial staining, so the epithelium was intact. So again, I didn't see him at this point, but the decision was made to continue the Lotamax, and then there was some concern for what role the Demodex was playing here, so they started increased lid hygiene and azocyte. And again, so he also was followed again on the outside, and a month later, you can see there's still this active stromal keratitis. So the differential includes many infections, possible etiologies. So the syphilis and HSV would be most common, but it also includes some atypical organisms. And so they did a corneal biopsy, which was superficial, and so it didn't show any organisms on pathology, and the PCR was negative. And so the patient, again, was still maintained on topical steroids, and they did the trial of topical Zergan. And again, several months later, the uveitis flared. They sent a workup again with an anterior chamber tap, which was negative. So at this point, this has been going on for some time, over a year, and you can see what the patient looks like. So you can see again, active stromal keratitis, and you can see the keratic precipitates here, and the vision is declining. So, on the outside, his outside ophthalmologist actually eventually did a full thickness penetrating keratoplasty for the patient, and so you can see here, you can see some of the organisms here on the Mason trichome stain, and it is at the interface, at the level of the interface. So you can see again these small ovoid organisms, and so further staining had showed that it was acid fast positive, and again other stains also revealed the organism. So this was, it turned out to be Microsporidia, which was originally a protozoan, but now reclassified as a fungi. And over 1,300 species, but 12 are known human pathogens. And in addition to affecting the eye, can affect the respiratory, gastrointestinal tract, kidney, and central nervous system. And the spore form is the infectious form. And most commonly causes a keratoconjunctivitis. First described in immunocompromised patients, but then subsequently also reported in healthy patients, and the keratoconjunctivitis is often self-limited. But in our patient who had the stromal keratitis, which is more rare, and in the literature, the series usually have about 35 maximum patients who they describe this in, and this occurs in immunocompetent patients. And I think one of the big take-home points is that the patients are often, there's a huge delay to diagnosis, and the mean duration of symptoms is what our patient had is pretty typical, which is almost a year. So you can see 332 days are the mean duration of symptoms. And risk factors, 50% of patients in the literature are reported to have trauma, and prior refractive surgery, as in our patient, is a risk factor. So, so I mentioned the keratoconjunctivitis. So these are the epithelial changes you can see. And in our patient, we had the stromal keratitis. So ultimately, in our patient, the tissue diagnosis and the pathology slides, which were actually sent to Wilmer, and read at Wilmer, were what made the diagnosis. But in culture, because it's a fastidious organism, it's difficult to culture. So we rely on the pathology stains, as I demonstrated. And electron microscopy can also visualize the organisms and identify the species. And also PCR can be a way to diagnose it. And the treatment that's been reported in the literature include topical fumagillin, fluoroquinolones, PHMB, chlorhexidine, and also systemic albendazole. And then many of the cases do require surgical treatment. So in this case, again, the penetrating keratoplasty. And so he actually didn't return to Wilmer, but had we've been in touch with the ophthalmologist and had a complicated post-op course. So I think the delayed diagnosis certainly contributed to the patient's final outcome. So I'm going to move on to the second case, which is something that we see not infrequently, not as infrequently as Microsporidia, but it was a 54-year-old male who presented again from an outside ophthalmologist with left eye pain and blurry vision. And this patient was a soft contact lens wearer, and of note was treated before presenting to us with Valtrex, as well as moxifloxacin and steroids at presentation. So when the patient presented, the vision was 20/60. And unfortunately, I don't have a picture from right on presentation, but I'll show you what he looked like several weeks after initial presentation. But basically on exam, it was noted that there was a possible dendrite, corneal edema, keratic precipitates, and trace flare in the anterior chamber. So there was a presumed diagnosis of herpetic keratitis. And actually the patient's topical steroid was increased, and he did have some initial improvement symptomatically. But then basically 2 weeks later represented and was feeling worse. And so, I think now the presentation is more clear. So you can see here, there's this ring-shaped infiltrate, and you can see the keratitis present on this picture with staining. So at this point, the vision was still good. And then it was recognized that this could be acanthamoeba. So the cultures were performed. So within 48 hours, the culture plates were positive, and the patient was started on treatment. But of note, this was over a month after presenting to the initial ophthalmologist. And then you can see here, and Professor Dart can tell us, so at this stage, you can see there is, it's much worse, and there could be even scleritis, so it's difficult. The treatment becomes much more difficult. And so it basically subsequently had a very complicated course despite the topical treatment, and then they eventually had to undergo cross-linking, and then the biopsy showed persistent infection, and then really the patient did not do well at the end of the day. And I think, again, it's due to the delay in diagnosis. So, and some of you may be thinking that it was an obvious diagnosis, but what we find in our referral patterns to Wilmer is that this diagnosis is still commonly missed in 2020. So we looked at Wilmer, we looked at our 70 over a 7-year time period, the cases of acanthamoeba, which were culture positive, and we had 45 eyes. And you can see that 96% of patients were contact lens wearers. And then importantly, you can see here that, so most were seen by an outside ophthalmologist, 70%. And then the majority, 70%, were also had over a month of symptoms by the time, they were referred and the diagnosis could be made. So, and then about 40% of patients were diagnosed with herpetic keratitis before referral to Wilmer. So, and actually I learned this during my time at Moorfields, that in a contact lens where before you invoke the diagnosis of a viral keratitis like HSV, that you really need to rule out acanthamoeba. And again, I think we still see the diagnosis is still delayed, and it's very difficult to treat once it's so advanced. And then finally, my last presentation is a more rare cause. And so this is a patient who I saw myself, who was a 73-year-old monocular gentleman who was referred for a corneal ulcer in the right eye. He actually had a complex ocular history in that eye, with a history of a trabeculectomy, cataract surgery, and sort of baseline corneal edema. The vision in that eye was about 20/70, had recurrent corneal epithelial defects, which was managed with a chronic contact lens. And the patient, because of the history of the edema and the epithelial defects, was on oral Valtrex, intermittent, on suppressive dose oral Valtrex, and some topical steroids for a presumed herpetic stromal keratitis. So that was sort of at baseline. And the other eye was gone totally because of advanced glaucoma. So when I saw the patient, this is what he looked like. His vision, unfortunately, was hand motions, again, in the better eye. And you can see the epithelial defect and stromal keratitis and hypopyon here. And on presentation, it had been several weeks where then they treated with a topical becifloxacin, and the patient was not getting better. So on presentation, we did corneal cultures, started him on fortified topical antibiotics. And basically what he ended up growing was this bacteria called Mycobacterium xylozoxidans. And so, and it was a resistant organism. So it was resistant to the tobramycin we were treating with, and gentamicin, and had intermediate susceptibility to fluoroquinolones. And so we did, based on the susceptibility panel, switch him to topical ceftazidime and polymyxin. And then a week later, he was better with resolution of the hypopyon. He was from about 2 hours away, so returned to his regular ophthalmologist. His vision did improve to 2400, still much decreased from the baseline. And then the ophthalmologist stopped the topical antibiotics after a 6-week treatment course. And then he was actually referred back to me for recurrence of the hypopyon. And you can see what he looked like. And so I did restart the treatment, and unfortunately, I couldn't reculture him at that time, because at the office I was seeing him at, we didn't have the culture media. So we sort of empirically treated. At this point, I was also concerned for possibly fungal keratitis, so did start voriconazole. And then after 3 weeks, the patient didn't do better. At this point, given he had a baseline history of corneal edema, and just was not getting better with the hypopyon and was monocular, I did do a therapeutic penetrating keratoplasty, and with an anterior chamber washout, and did irrigate with ceftazidime, vancomycin, and voriconazole in the event it was possibly fungal. But the corneal button still grew the same organism as he did on presentation, and it was deep in the stroma. And so fortunately, because he was one-eyed, he did do well with his vision is about 20/40 now. And so that's a case of the Mycobacterium, which is a rare infection, gram-negative organism. Because it's health immunocompromised patients can cause other systemic infections, but in the eye, risk factors for the infection include a previous history of a corneal transplant, or as in our patient, topical corticosteroid use or contact lens wear, which he had both. It tends to be a less fulminant presentation than Pseudomonas and indolent, and there is a delay in diagnosis of this organism, and it is also tends to be multi-drug resistant. So early diagnosis certainly can help in avoiding the worsening as we saw in our patient. So in summary, we talked about 3 cases of delayed diagnosis, which did affect the outcomes. And so just microsporidia should be considered in any case of prolonged stromal keratitis, which is culture negative and doesn't respond to conventional therapy. We discussed ruling out acanthamoeba and contact lens wearers with any atypical keratitis. And then finally, the Mycobacterium is a rare cause of bacterial keratitis, often in sick eyes and multi-drug resistant. And in all of these cases, early diagnosis is essential. Thank you.
Thank you very much, Dr. Woreta, for very nice presentation and nice cases. These are the diseases that many ophthalmologists are not familiar with them. And thank you for presenting these cases. I think, Dr. Soleimani, I am worried about the time. So I suggest that if the panelists or speakers don't have any comment on this subject, we'll go ahead with other speaker because I am worried about the time. And after that, if you have time, you can present your cases. Do you agree with this? Or first of all, I would like to ask any panelists if they have any comment on this subject, on these cases. Please give your comments. And after that, I think we will go to the next speaker if Dr. Soleimani agrees. So, and there may be some questions related to surgical management of these cases. I think I will have a few minutes later on to just discuss surgical management in the next part. But at this time, do any panelists have any comments? Yes, John, please go ahead. Your microphone is muted. Can you unmute your microphone? And yes.
Thank you very much, Fasika. Samir Jabbar sends his best wishes. Anyway.
Please send my best wishes. He's wonderful.
I will. He's doing very well. I lecture to him every Thursday. That's not what I wanted to say. Just about the microsporidia case, we've actually had 3 stromal cases, so it's on our list of difficult organisms. And our protocol now is, if patients coming to we see about 800 cases of keratitis a year coming through our emergency department, and anybody who has something which doesn't really look like bacterial keratitis or is not improving at 5 days after intensive antimicrobial therapy, antibacterial therapy, goes straight through to our specialist service, and they all get IBCM, PCR, and culture, whereas we don't culture most of the bacterial cases. And I think it was a shame that microsporidia case wasn't biopsied. We would have probably done a biopsy early on in the periphery. It was easy to do, and would have picked the case picked the case up a bit earlier. But having said that, I think the outcome of most of those microsporidia is terrible, and he will have microsporidia in the periphery, and he's going to do badly. The amoeba, we've just audited our herpes cases at Moorfields over 1/4. And interestingly, it's something I wanted to do, but I couldn't face getting out all the herpes cases. And for the same quarter, it was last year, we had 3 epithelial herpes in contact lens wearers, and we've had 3 grade 1 acanthamoeba patients who are contact lens wearers with a similar epitheliopathy. We actually had another 4 or 5 acanthamoebas with more severe disease or combined with bacterial disease. So in the UK, and quite possibly Berthold in Germany, and maybe in Iran, you know, as Fasika said, you really got to consider amoeba as well as herpes in patients, particularly contact lens wearers presenting with an epitheliopathy, which might be infected. It's a big problem. It's not misdiagnosed at our hospital anymore. We've audited that, but it's taken a long time to get the message across.
Okay.
Germany,
yeah.
Germany, it was until 10 years ago that 2/3 of acanthamoeba was initially misdiagnosed as herpes. It was really a mess. But now, as you said, John, now we have learned and we do that much better. But 10 years ago, it was terrible.
Yeah, I agree with you. Actually, I have a memory from back in '99. I was at Moorfields visiting Moorfields, and I learned the first case from John Dart. It was a acanthamoeba case. And then I went, at that time, I was with Mr. Steele. And I went to US in a center, very famous centers. And they were following a case with diagnosis of herpes. And because I had this idea from Moorfields, I told them that this may be acanthamoeba. And they investigated everything and finally said, no, this is not acanthamoeba. But the patient didn't respond again. And then they did biopsy. And finally, it turned out to be acanthamoeba. So in the past, it was a lot of challenge with this diagnosis of this casing, and they were diagnosed as a herpes, but still they are, you know, in some cases, still there is the diagnosis challenging. Okay, thank you very much. Yes, yes.
Patient not improving needs to be investigated for Microbacteria, Nocardia, Mycobacteria, amoeba, herpes. You know, we have that panel and we look for all of those, even though we've only seen Microsporidia 3 times in the stroma, but it happens. Okay, thank you. So do you agree that we go to the move to the next presentation, and after that you will present your cases, because I am just worried about the time. So if you agree, I will introduce them.
Do you hear me?
Yes, yes, please.
Yeah, I agree, and I have a comment. In early cases, Atypical Keratitis could be misdiagnosed as Herpetic Keratitis, and in later cases of Atypical Keratitis, it could be misdiagnosed as Fungal Keratitis. I have too many cases of Atypical Keratitis in earlier stages that was treating instead actually as a Herpetic Keratitis, and in later stage I have visited too many cases of Atypical Keratitis as treated as Fungal Keratitis.
Okay, thank you very much. Can you see my screen?
Yeah.
Yeah. Okay. I'm going to introduce the next speaker. He is the last and not the least speaker, Dr. Kendrick Co Shih. He is from Hong Kong. He is a clinical assistant professor of the Department of Ophthalmology, University of Hong Kong. He is specializing in cornea and ocular surface, and I'm sure he has a lot of experience with these cases, and he is going to present his, to give his talk on atypical keratitis and maybe nocardia or other cases. Thank you very much, Dr. Shih. Can you start your presentation, please?
Okay, sure. Thank you, Dr. Qureshi, and also Dr. Soleimani for the invitation. I'm no expert, but I'm very grateful to be here today, sharing just some knowledge with the giants in the field. So what I'm going to focus today on my talk is non-tuberculous mycobacteria or atypical mycobacteria, and also nocardia keratitis. So I don't have any financial interests in the drugs or products discussed here. So I'm starting with a case scenario. So it's a 23-year-old male university student, younger brother of a nurse at the hospital, presenting with a one-day history of right eye, sudden vision loss, severe pain, redness, and tearing. And the vision was hand movements only on presentation. So this is what it looked like when I saw the patient. Visual acuity was hand movements. You can see a very large, dense infiltrate in the, this was the temporal cornea. And aside from that large, dense infiltrate, you can see that the rest of the infratemporal half of the cornea is a large epithelial defect with some patchy infiltrates in that area. My initial diagnosis was right eye infective keratitis of presumed bacterial origin, but now looking back, I think there were some warning signs that I should have paid attention to. The first thing is that this patient is a non-contact lens user, good past medical health, no trauma history, went hiking 2 to 3 days prior to the presentation, and the sister, being a emergency nurse, prescribed several drops of levofloxacin 1.5% to the eye prior to consultation. So I did cornea scraping for bacterial and fungal culture and admitted the patient for intensive hourly application of levofloxacin 1.5% and tobramycin 0.3%. Now this is the second day, so I started to notice that the infiltrates appeared to be coalescing, and also the epithelial defect was shrinking. Visual acuity was count fingers, and on the third day improved to about 0.2. I thought the infiltrate size was starting to shrink as well. Now this is day 5, so this was the controversial part because the visual acuity was clearly better. The eye was a little bit less red, but if you look at the infiltrate, it seems to start to branch out. There's something growing just adjacent to the initial large infiltrate. And I just continued with the treatment. Bacterial culture was negative for growth. The fungal culture was still pending. Epithelial defect had completely resolved by then. So I thought I was on the right track until day 8. This is what it looked like. There was a clear new focus of infection adjacent to the large infiltrate, and the visual acuity was dropping as well. So at that point in time, I did a cornea scraping for bacteria, Acephalus bacilli, herpes simplex, fungus, acanthamoeba. After listening to the talk, I probably should have done microsporidia as well. But what I noticed was when I was doing the scraping, the lesion was quite superficial. So it seemed to be involving the epithelium, subepithelium, and also the anterior stroma. And so at that point in time, my working diagnosis was non-tuberculous mycobacteria. And I started the patient on amikacin 2.5%, levofloxacin 1.5%, and oral clarithromycin. I subsequently changed the levofloxacin to moxifloxacin 0.5%. So just going into a little bit about non-tuberculous mycobacteria or atypical mycobacteria. So this is a group of 150 species widely distributed in the environment, particularly in soil and water. Hence my suspicion, because the patient was hiking. So I was thinking he might have been digging his hands in soil, washing his face in streams. Human disease from NTM is a result of environmental exposure rather than human-to-human spread and zoonotic spread. It was first reported in 1965, and keratitis is the most common ocular manifestation. Now, it can occur in immunocompromised patients, but in NTM keratitis is most commonly found in immunocompetent patients. So it's not the suppressed immune system that's the issue, it's the contamination during trauma or during surgery. So we can look at typical mycobacteria, which is basically your mycobacteria for leprosy and tuberculosis. That's high virulence, usually spread from humans to humans, sensitive to standard anti-TB meds, and tends to be slow growers. Whereas atypical mycobacteria, the ones that we're dealing with, they have lower virulence, spreads from environment to humans, resistant to standard anti-TB meds, and you have your fast growers and slow growers. They do account for a minor proportion of infectious keratitis, but they account for almost 50% of post-LASIK keratitis. I think one of the reasons is because of the use of broad-spectrum antibiotics after LASIK, so removing most of the common infections that we see. So we do see outbreaks related to improper sterilization to LASIK techniques, LASIK equipment. And especially the rapid growers are the ones that we're concerned with, fortutum, chelone, and also abscessus. And they account for about 70% of these keratitis cases in the world. Now, the risk factor is basically contamination rather than any underlying medical or ocular factor. And so you see it in LASIK SMILE. We had a recent case in a Boston K-Pro requiring explantation and retransplantation. They also are seen in cataract surgery and even extraocular surgery. They can also be seen related to trauma and cornea foreign bodies, and also contact lens use and steroid use, although maybe less to a lesser degree than, say, acanthamoeba. So the clinical presentation is a milder form of the infectious keratitis, and the classical sign is that cracked windshield appearance, where you have these radiating lines from a central infiltrate, and oftentimes because of the indolent course, the epithelial defect can be healed. They also do masquerade as other types of keratitis, such as fungal keratitis, so they have satellite lesions, dendritic lesions like herpetic, and also crystalline keratopathy with the sort of branching intrastromal opacity, the ground glass appearance. The depth of the infiltrates is dependent on the depth of the trauma, and hypopium is usually quite rare. The most important thing is that the presentation tends to be delayed. It can be 1 week, 6 weeks, even up to a year after exposure event, and it tends to have an indolent but waxing and waning course, and it tends to respond poorly to traditional therapy. So I think the most important thing is making a diagnosis, and this is usually delayed because of a low index of suspicion. Cornea scraping with acid-fast staining can usually give you your diagnosis, although culture and sensitivity testing gives you the added bonus of sensitivity testing with antibiotics. It may take 1 week or up to 8 weeks for some of the slow growers. We don't have PCR-based technology for atypical mycobacteria, but if you do have that at your center, that would be a very quick and specific diagnosis. Sometimes you have to resort to cornea biopsies or even a therapeutic PK for making the diagnosis. So the medical treatment is the first line, but it has limited effectiveness alone, usually due to inadequate drug penetration, resistance, and also local toxicity. Amikacin is the drug that is the mainstay. So, for example, what we could use is 2.5% amikacin, gadafloxacin with oral clarithromycin, which is quite a similar treatment that I gave. And there's no real set duration of therapy, but you really taper it according to the clinical response. Surgical treatments, they occur in more than 50% of the cases. Sometimes that involves just lifting a LASIK flap and irrigating it, or to the point of superficial keratotomy or therapeutic PK. Prognosis is variable, so a lot of the information that we have are in case reports, which tend to report better outcomes. And so I think one of the risk factor for poor visual prognosis was surgical intervention. Just another possibility. So one of the things when we think about atypical mycobacteria, we also want to think about nocardia. So this was originally classified as a fungus, but nowadays we know this is a filamentous bacteria, gram-positive, aerobic, also is acid-fast. And there's about 12 accepted species. Like Mycobacteria, they do live in the soil, mud, and dust. So again, in our patient, it could also be a possibility. And they are not seen in normal flora. So the risk factors are similar to fungal keratitis and NTM keratitis in terms of trauma, surgery, corticosteroid use, and contact lens wear. And usually the traumatizing agent is vegetative material, flying insect stone, so very similar to NTM and fungal keratitis. And as we know from the SCUT trial, use of steroids can, in nocardia cases, can increase the resulting scar. So what does it look like? So the reason why I thought, this group of infections was because of the relatively superficial nature. So here you can see it starts off as a initial punctate epitheliopathy, and it moves on to mostly the anterior stroma, epithelial and subepithelial tissues, and it gives you that classical wreath-like pattern with satellite lesions. One of the things that may point to this more than the mycobacteria is that in these cases, the cornea tends to be hyperesthetic, so they tend to be in a lot more pain. That was seen in our patient where he wasn't able to open his eyes even with the treatment, and even while he was recovering, there really wasn't much improvement in his pain. So oftentimes you can see in this case, they can coalesce into a white infiltrate, which can ulcerate and start to melt the cornea. The diagnosis, if you do have, it's gram-positive branching beaded filaments that stain with 1% acid-fast stain. But if you culture them in blood agar, chocolate agar, or Sabarod dextrose agar, they can grow usually within 3 days. And if you isolate, this is usually clinically significant. So in terms of treatment, again, it's initially with medical therapy, and again, amikacin is the treatment of choice. Some of the second-line therapies may be effective as well. But surgical treatment is usually warranted in progressive thinning, extension beyond the limbus, or presenting at an advanced stage. So just in summary, non-tuberculous mycobacteria is rare, but potentially devastating. Variable prognosis, usually due to delayed diagnosis or initial misdiagnosis, and either incorrect treatment or drug resistance. Represents a minor portion of infectious keratitis, but more often seen in LASIK keratitis. Having a high index of suspicion, timely diagnosis, and proper treatment have been shown to be vital in good outcomes. So I think it's also important to treat the current reports with a grain of salt, because the apparent higher diagnostic yields, improved outcomes may be affected by publication bias. And there also remains to be a standardized protocol for management. So, but as long, from what I know, I think Singapore National Eye Center now uses amikacin as the first line in combination with at least a fluoroquinolone and also possibly a macrolide in their treatment. And treatments titrated according to the antibiotic sensitivity results. So if you can get a culture result, that's the best. And nocardia is an important differential diagnosis, especially for keratitis that does not respond initially to broad spectrum antibacterial therapy, and also especially those without a contact lens history use. And in terms of the similarities to NTM keratitis, they are in terms of the risk factors, prolonged clinical course, and also use of fortified amikacin as the mainstay. Yep, so thank you. So that's just my relatively brief overview of this. So thank you for listening, and it's my pleasure to have presented here today.
Thank you very much, Dr. Shih, for very nice presentation. I think that we have not much time, and I think Dr. Prajna has to leave in 5 minutes. I don't know if he's still there. So before he leaves, can you hear? Okay. So before he leaves, I think I have to ask him if he has any comments on Dr. Prajna on surgical management of these cases, especially fungal keratitis. Are you here, Dr. Prajna?
Yeah. So
okay. Can you comment on surgical management of fungal keratitis and also the immunosuppressive therapy in these cases?
So my take on this is when you are actually documenting an increase in your fungal keratitis, after making sure there is no drug contamination or anything else which is contributing to that increase, because that is one thing I really would like you to be cautious about when you're actually dealing with the case of fungal keratitis, treating with antifungal medicines. And suppose if it just flares up, please think of a Pseudomonas contamination of your antifungal drops. If that is not the case and still the ulcer is increasing, I would advise to consider a TPK at the earliest possible time when you have the rim remaining at your disposal. That would be my choice.
Okay, thank you very much. I think Dr. Soleimani has very nice cases, but I don't think that we have time to go through his cases. So can I share my screen? Please.
Professor Qureshi.
Yes.
We can show one of my cases regarding the surgical treatment or medical treatment of fungal keratitis. If I think that we have 2 to 3 minutes.
Okay, that's good, because many patients had many audience had the question on surgical management and immunosuppressive therapy in these cases. And I would like right now to thank Dr. Prajna if he wants to leave earlier. So thank you very much. Very nice presentation, and I would like to thank you again. And if other panelists and speakers have time, we can continue for a few minutes. Otherwise, we have to finish in 5 minutes. So Dr. Soleimani, can you present one of your cases?
Yeah. This is one of the cases. This is a 33-year-old patient, farmer patient, presented to our emergency department after hairborne material trauma. On slit lamp biomicroscopy, you see a feathery border infiltration in the central part and a ring infiltration in the periphery of the lesion. Actually, we did a scraping, and in the scraping, mycelia was detected. This is the confocal scanning of the patient. You see interlocking and branching hyphal structure. After 7 days in culture, we actually detected pseudo-Algeria boydii. So we started topical treatment with voriconazole and also systemic itraconazole for the patient, and also topical levofloxacin for antibacterial coverage. However, the problem was that after 16 days, a hypopyon was present in the anterior chamber. However, the size of infiltration was decreasing, and a scar formation in the periphery of the lesion was present. In this stage, I want to ask Professor Prajna regarding the management of this patient when the size of hypopyon is increasing and infiltration size is decreasing.
So, I mean, it's a very nice situation, and I would, we see this situation quite often. I would not be too perturbed about the hypopyon per se. The only thing is, I know that the stroma infiltration and the defect is healing very well. That's a very, very good sign. The only suggestion at this point of time is I would dilate this patient even more to actually take care of the inflammation in the chamber and just continue the same medication.
Yeah, actually, we did an smear and culture for the patient to find is there any superinfection for this patient, and there was not any superinfection in smear and also culture. So, as Professor Prajna said, we continue treatment, and it was the confocal scanning of the patient. You see decreasing hyphal structure in the confocal scanning. So, the patient we continued the treatment. In the summary, in the confocal scanning, the density of hyphal structure was decreasing, so we continued the treatment, and after 6 weeks, there was a faint infiltration in the central part, and there was a near total scar. There is an important point in this slit photo that whenever we have a corneal infiltration without any epithelial defect, we should continue antifungal therapy till complete disappearance of infiltration. In fact, if we discontinue the antifungals or start topical steroid, the fungal infection would flare up. And this is the confocal scanning at this stage. You see the density of hyphal structure are decreasing, and according to the confocal scanning sequence, the topical voriconazole was tapered down during 2 months, and it was discontinued after 2 months. As you see, the density of hypha is decreasing during the time, and it could establish the role of confocal, actually serial confocal scanning in the follow-up of the treatment of fungal keratitis.
Thank you, Dr. Soleimani. Do you want to continue?
No, actually, the case was related to pseudo-Algeria boydii. It is a rare cause of fungal keratitis. However, actually a common cause of eumycetoma that Professor Prajna know, and it could result to lower or upper limit amputation.
Okay, thank you very much, Dr. Soleimani. I think we have out of time, and I just want to ask if panelists and the speakers can stay a few minutes more. Otherwise, we have to conclude. It is up to you. I think Dr. Prajna would like to leave. I'm not sure, but just can you tell us you can stay or you have to leave?
I can stay. I can stay, Dr. Qureshi.
Okay, thank you. Just I am presenting this case. Actually, cases of Dr. Soleimani were much more interesting, and he had a lot of interesting cases. But I think we don't have time to continue with his cases. But
can I ask a question?
Yes.
How about washing the anterior chamber repeatedly with antifungals? Do you do that, especially if you have a lot of hypopium?
I answer, or Professor? Actually, I don't do it because when you washing the anterior chamber, there is a risk to nest the fungi, for example, into the vitreous on other part of the eye. I have a case of washout of anterior chamber for Mycobacterial Keratitis that there was a nested infiltration in the site of entrance of double cannula.
Okay.
So I don't do it.
Do you? What's your own opinion? Do you wash?
Professor Prajna.
No, I don't wash. I don't wash the antechamber. I don't like to create any wound, even in the periphery of the cornea, when I know that the fungus is lurking around anywhere. I just don't like to create a wound. Okay,
thank you. But let's go to my next slide, and I will ask the timing of keratoplasty. So Dr. Prajna already answered. I would like to draw the idea of John about the timing of keratoplasty. So I had a case of fungal keratitis that didn't respond to treatment, and I did all the things for her, and ultimately I did the keratoplasty for this case, and this is the result of keratoplasty. The patient developed an episode of rejection. So can you comment on the timing of keratoplasty and the immunosuppressive that you use after surgery for this case? John, please. Do we have? I
think John, you have to.
Yeah.
We can't.
What is the best time for corneal and fungal corneal graft after fungal keratoplasty, and does it apply to any other cases?
We can't hear John. I think he's speaking, but somebody has to unmute John.
Can you unmute?
Dr. John Dart, please. Can you unmute Dr. John Dart?
I don't know.
Yeah, that's.
Is he unmuted?
In between, he was unmuted. Yeah, now it's okay.
Yeah, it's okay. It's okay.
Was that a fungus case, Mohammed?
Yes, that was fungus. Yeah.
Yeah, well, Prajna is the expert on this. I mean, I do what he does, and if we have a protocol which allows, we use Natomycin as our first line. If they're not improving after 7 to 10 days, we switch to, or we'd add in chlorhexidine or amphotericin, chlorhexidine 0.2 or amphotericin, and if they're still getting worse, we then operate. So usually we have 2 changes of treatment, and would operate if they're still deteriorating at usually about 3 weeks. So it gives us a chance to give 2 changes of treatment. And that's because, you know, as Prajna said, one fusarium is not like another, and those are usually the worst cases. They all behave completely differently, and some of them just don't respond. And I'd rather get in when I can do an 8mm keratoplasty with a clear margin than have to wait until, you know, you have to do a huge graft later. But I learned all this from Prajna, Prashant Garg, and Eddie Alfonso.
Okay, thank you very much. Myself have a principle for myself. I'm not you know, advising to other people, but myself, I will go after the principle, like something like when you want to put a capsular tension ring. So it's said that what is the best time for capsular tension ring? So, and the best time is as late as possible, as soon as necessary. I think the same rule applies to keratoplasty. So I would say the best time is as possible, as soon as necessary. And the time of necessary is up to the physician. So if I don't know if you agree to this principle, because I think that latest if it's done, if the eye is more quiet, it's controlled better, so the result is better. But in many cases, maybe it is necessary to do earlier. So I think I suggest this principle. I am not sure it is right or not.
Well, my view for the other causes of keratitis is pretty much the same. I mean, we don't operate. Bertold and I have had a discussion at a major meeting about whether to operate early or not for amoeba, and I won't operate before 9 months because we can get most of our patients cured by then. But for fungus, you know, that's the only condition which we operate early.
Early. Okay, that's very good.
I think you should operate before the fungus, especially Fusarium, penetrates Decimate's membrane, because once that's I have very little experience, but once it's in the anterior chamber, it's much more difficult. And we also learned that the 8 or 8.5 graft is typically too small. Now we start with 9.5 grafts from the beginning to get out everything and put them in a lot of single sutures, and also some voriconazole intrastromally in the host rim. I think that may be a good.
That's a good thing to do, because it prevents recurrences if you put it in the host rim. I think even we do that. And important thing is, I think for fungal keratitis, I don't know whether others are giving immunosuppressives or not, but we like to give topical antifungals post-operatively and start steroids only after epithelialization is complete or when there is no recurrence, most likely which happens 2 to 3 weeks post-operatively.
Now, Namrata, what is the role of cyclosporine? I learned through the rehearsal for this meeting that cyclosporine may have an antifungal effect. Is that true? So
we have not used cyclosporine, but yes, it is said that it may have some fungistatic action, but we've not used cyclosporine post keratoplasty for fungal keratitis.
Thank you. The question is, okay, you already answered the question, Dr. Namrata. Thank you very much. So I want the opinion of other participants about the timing of steroid or maybe cyclosporine. Can you comment on that, John?
Well, I'd love to know what Prajna thinks. We stopped using steroids after. I know I've discussed this with Namrata. We have far smaller experience, but we've had such bad experiences using steroid after fungus. We tell the patients that, mostly Steve Tuft and me, that we're doing the transplant to get rid of the disease, and we'll sort the vision out later. So we don't try and keep the transplants going with steroids if they're rejecting, because we've had fungus recur up to 3 or 4 months after the absence of any adverse clinical signs. So we don't use steroids at all, and we sort out the vision later, having got rid of the fungus. We will use cyclosporine, but whether it does any good or not, I don't know. I don't think it does any harm. It's slightly antifungal. In vitro, whether it decreases inflammation, I'm not sure. It has no role in preventing rejection.
Okay, thank you. There are some reports about the antifungal effect of cyclosporine. Of course, it has some antifungal effect, but it cannot be used as an antifungal in microbial keratitis. But there are some supports about the antifungal effect of cyclosporines. I think we have to conclude. The time is over. We have.
Can Prajna make a comment, Mohammed? Because Prajna he's got a big experience like Namrata.
Yeah, no, I completely second Namrata and John on this. Because I always tell my fellows, the reason why you do a keratoplasty for fungal keratitis is not for visual recovery. It is for controlling the infection and preventing secondary glaucoma. We always wait for a better day for everything to quieten down and then plan for an optical keratoplasty. So I don't use topical steroids at all when I'm doing a TPK for fungal keratitis, at least for the first 1 or 2 months. I don't use steroids at all.
Okay, I think, yes.
Another thing I think needs to be emphasized, I think everybody knows it, that DALC should not be done for, as a therapeutic DALC should not be done for fungal keratitis, because the fungus penetrates much deeper than what it looks actually even clinically.
Yeah, that
actually,
is
one of my cases, but DALC treatment actually bulk for fungal keratitis because it's not too deep to the desmal membrane. But Professor Prajna will discuss regarding the treatment of bulk for fungal keratitis.
No, I told that same point which Namrata was mentioning to Dr. Soleimani on that day also. You can get lucky with 1 or 2 cases, but I have a deep respect for fungus. And I don't really mix, this is where we get into a problem by looking at 1 or 2 sporadic cases, nice cases, which we might just escape and gives a very good result. I'm not a big voter. We all tried it. We all went through that same grind. And now we've come to a deep thing that I don't do a DALK for fungal keratitis.
Actually, the cases that Dr. Soleimani had two cases that they already had DALK, and after that he did REDALK. But I think you're right that initially we would not recommend DALK in these cases. But Dr. Soleimani had also a case of doing DALK, but 2 cases that had previously DALK. So I would like to thank you all the participants, speakers, and panelists. If anyone has any final words, Professor Slade, do you have any final words to say, and we'll conclude?
I'm now more than 30 years in the field of ophthalmology, and when I was young, we saw maybe some candida every year. And now since 2013, even in Germany, we see lots of fungal keratitis, especially fusarium. And initially we made a lot of mistakes, but over the last 7, 8 years, I think we get to know it because we have much less experience than Chinese and Indian people. But in Europe, we have to deal with it now because it's becoming more and more, maybe due to the climate change.
Okay, thank you very much. And I think we have to finish. If any other colleagues they don't have any comments, any words, I am sure that there are a lot of questions that we could not answer, especially after refractive surgery. There are more cases coming, and unfortunately, we didn't have the time to go through all of them. So I would like to thank all of you and hope to see you in person in the future.
Thank you very much.
We have to take a photo at the end of session. Yes. IT team, please, IT team, are you here?
We would like to have a snapshot from all participants. And I would, okay. And I would announce that our webinar was streaming on Facebook. I am sure that many people watched on Facebook our webinar. Are you ready?
Thank you. I'm thankful to you because I could see John after many days, and I could see Dr. Seeds after many days, and Prajna also after many days, although we live in the same country.
Please be ready. I'm going to take a photo.
Dr. Woreta is not there.
I'm here.
Here we don't have. We don't. Oh yes. Okay. Yeah.
In your car.
Okay. Good.
Yes, I did.
Okay. Thank you very much.
Thank you.
Thank you all. Thank you. Bye bye.
Lovely to see you.
Thank you.
Very nice to see you all.
Thank you.
Thank you, John. Thank you very much.
A pleasure, Mohammed. Thanks so much.
Thank you.
Bye, Namrata.
Bye, John. I was remembering your Castrovigio lecture. It came on my Facebook.
Thank you.
You can continue if you want. If you want to talk personally, you can. Okay.
No, it's okay. It's okay. I'll call up John.
Really nice to speak. And thanks very much, Mohammed Qureshi.
Thank you, Dr. Qureshi. Excellent.
It was really good conference, actually. I thoroughly enjoyed it.
Thank you.
Thank you. Bye.
Bye.